everyone. I'm Dr. Ajay Duseja, and I work as professor in the Department of Hepatology at Postgraduate Institute of Medical Education and Research, Chandigarh, India. And it's my honor today to chat with Professor Patrick Kamath, Professor of Internal Medicine and Hepatology at Mayo Clinic, Rochester, Minnesota, US. So welcome to the chat show.
Oh, thank you, Ajay. Thank you so much.
What we have been assigned is that we need to chat, or we need to talk about the prevention of cirrhosis. And before I get into that, I must say that I'm really honored to chat with you today for maybe two reasons. One is obviously there's no match for you in hepatology, the amount of work you've done, so-called, we call you as a MELD man. And the score of MELD, what we use day in, day out, prognosis, allocation, whatever, is all given by you. And the other reason I feel, other than your work in hepatology, is that you are an alumnus of PGI Chandigarh, and we feel proud that we come or we work now at the same place where you were trained and which was your alma mater. Really proud of that.
No, I'm really proud to be from PGI. I do not have any US training, and all my training has been in PGI. So where I am today, I owe largely to PGI, but many other institutions that I trained in.
Sure. So as I said, I think we need to chat about prevention of cirrhosis, and cirrhosis we know is a big killer in liver disease. Before I get into the, what kind of prevention, how to do that, I mean, do you think the kind of patients with cirrhosis, what you see in US or globally, would be different from what we see in Asia Pacific and India, or they would largely be the same?
About 2 million people die worldwide from liver disease, specifically cirrhosis. Alcohol-related cirrhosis accounts for about 1 million deaths a year. An additional 200,000 or so might be related to alcohol-related hepatitis. And you know the division between alcohol-related hepatitis and cirrhosis is difficult. So at least 50% die of alcohol-related cirrhosis.
Right.
The remaining 800,000 to 1 million are dying of complications of hepatitis B, hepatitis C, and non-alcoholic fatty liver disease. So this is worldwide.
Right.
In the United States, we will have more of alcohol-related liver disease, non-alcoholic fatty liver disease, and hepatitis C. Hepatitis B is more with immigrant populations.
Right.
Whereas if we look at Asia, then depending on which part of Asia it is, we'll have more hepatitis B or C. But I still think worldwide, whichever country you look at, except in countries where alcohol use is prohibited, it's going to be alcohol-related cirrhosis, non-alcoholic fatty liver disease-related cirrhosis, and viral hepatitis B and C.
Yeah, I think I agree with you, and this is also peculiar to India. I think alcohol is top on the list, and maybe followed by viral hepatitis combined together, and then maybe non-alcoholic fatty liver disease. But when you say that, I mean, and we are restricting ourselves only to the cirrhosis, and you said complications of cirrhosis as well, are you taking into account the liver cancer or HCC also as complications of these diseases as killer?
Yes. So when we talk about 2 million deaths of cirrhosis, we're including hepatocellular carcinoma. So when we look at global registries, hepatocellular carcinoma does not always say whether there was underlying cirrhosis or not. You know, that diagnosis is a little difficult. Also, when we say cirrhosis, they may actually have hepatocellular carcinoma in addition, but they're dying of liver failure. So these numbers, I think it's the 2 million, which is the important number from chronic liver disease. The actual breakup is probably questionable. But in general, we have to remember that alcohol-related liver disease is half of all deaths. So if we're talking about prevention, we're talking about prevention of alcohol-related cirrhosis, non-alcohol-related cirrhosis, which is fatty liver disease, as well as viral hepatitis.
Okay, so I mean, you said these are the three important causes, and then all these three look preventable. And if they are preventable, me and you are going to be out of business. So leaving that point beside, no, I think what we need to chat today, what we're chatting today is how do we tackle each one of this alcohol, non-alcoholic fatty liver disease and viral hepatitis and prevent people to get into cirrhosis. So either they don't start alcohol if somebody is already taking alcohol and he's at an early stage. How do we prevent him to get into cirrhosis? Similarly for non-alcoholic fatty liver disease. I mean, so maybe you can elaborate one by one. How do we prevent, say, somebody getting alcoholic cirrhosis and the other etiology?
If we are out of business, it's actually very good for patients.
Yes,
so
absolutely.
ultimately, that's the goal. The goal might be for us to be out of business,
Absolutely.
okay?
Yeah.
So let's take alcohol. So half or more of all deaths are related to alcohol. There are various methods that have tried to try and prevent alcohol-related liver disease. So people have tried education even at very early ages.
Right.
But the only thing which seems to work is regulation at a government level.
Right.
So if we look historically, we have to look at the old Soviet Union. When Gorbachev became president, he cut back on alcohol use. Alcohol was more difficult to get in the old Soviet Union, and alcohol-related problems, which is not only liver disease, it is accidents, it is violence, all that decreased. 1991, Boris Yeltsin became president. He reintroduced alcohol. In the first 2 years after that, sharp increase in alcohol-related hepatitis deaths, sharp increase in violence and accidents. So we know at a government level, it's the most important. The second,
Sorry, but then does it really work at, you're giving the example of Soviet Union, how about other countries and take, say, India, some of these states did some prohibition, but finally, I mean, it worked at some places, it doesn't work. So, I mean, what do you think? I mean, the government policies, is it easy to implement, difficult? The kind of taxation or the excise they get out of selling alcohol and all that stuff?
yes, so we have to take two separate examples. We have to take Scotland, where things have worked, and India, where things may not work. So we have to compare Scotland versus England. Okay, so they're both part of the same, sort of almost United Kingdom, almost. So Scotland, which we associate with alcohol production, has implemented a policy where the cost of alcohol each year is higher than cost of inflation. So 1 to 2%. So let's say inflation is 5%. Next year, alcohol tax will be 7%. And then the following year, if the inflation is 10%, the cost of tax will go to 12%. So gradual stepwise. Second, hours of sales. If you restrict the hours of sales, cut back on alcohol. And so already we are seeing the benefit of decreased alcohol consumption in Scotland. England has not made the changes. In fact, England has made the cost of alcohol cheaper, and hours of sales have become longer.
Right.
And alcohol-related problems have increased. So we know that works there. Iceland, the best example, but I don't like to take Iceland because it's a country of 400,000. It's much easier. India is a bit of a problem because the moment you prevent legal sales of alcohol, it's the illegal sales of alcohol which increases. That may be difficult. But having said that, current government policies have made it easier to buy alcohol. So in Tamil Nadu, there was a law that no alcohol should be sold within 1 kilometer of a highway.
Yeah.
They wanted to prevent accidents. But that means more than 1 kilometer from a highway goes close to rural areas where people live, so alcohol use is increased there. So that is difficult. It requires changes at society level, understanding, as well as at government level. So I don't quite know what is the best policy for India.
Right. So, but then, and this is obviously, alcohol abstinence would be the best policy if you really want to prevent the alcoholic liver disease. But then, those who have been drinking and say are undergoing routine executive checkups, and they are told to have that they just have hepatic steatosis, no fibrosis, no alcoholic hepatitis, anything for them which make them say abstinent so as that they don't progress further, and either they leave it off obviously, or some kind of drugs or something, any other interventions which can be done on them so that they don't progress or they leave or whatever.
So that's a good point, Ajay. I think every patient, no matter what they come for,
Right.
should ask for alcohol use. Like we ask for tobacco use, we must ask for alcohol use. And all patients should be counseled about safe consumption of alcohol, so safe limits.
Right.
So we generally take what is called the 4-14 rule for men and the 2-7 rule for women. So the 4-14 rule for men means not more than 4 drinks at one time or any time,
Right.
and not more than 14 drinks per week.
Per week. Yeah.
For a woman, not more than 2 drinks at one time,
Right.
and not more than 7 drinks per week.
Per week.
But there's also a problem with that. That is if you are not overweight. If you're overweight, even those amounts of alcohol
Absolutely.
might be a problem.
Mm.
Additionally, we should never encourage people to drink saying 1 glass will help cardiovascular. The WHO does not recommend that, because 1 drink of alcohol per day increases risk of breast cancer in women.
Right.
So in general, we should counsel them and recommend no alcohol use or really minimal alcohol use. I think that is what our goal should be. Once people start drinking, which is at unsafe levels, they need not necessarily have addiction. So the use disorder, because you can get alcohol-related liver disease without addiction. They don't have the social and psychosocial aspects
Right.
of it. But once they drink, then the question is, can we have behavioral intervention, or should we have drugs?
Drugs.
So in liver disease, there is a little difficulty because the safety of the drugs has not been clearly demonstrated. So within the United States, for instance, we are involved in small studies trying to look at acamprosate, see whether that's safe. Baclofen has worked again in small studies,
Right.
but we don't know in advanced cirrhosis whether it actually helps or not. Okay, so currently it has to be behavioral therapy. The role of drugs is still not clear.
Absolutely. I think you already touched that point which the proponents of alcohol sometimes take, that do we have the extra hepatic benefits of alcohol. You did touch on the cardiovascular and the issue of breast cancer and all that. So I think negating all that, so the alcohol should be a big no for everyone, leaving aside all the benefits which we're talking about.
One of the problems worldwide is that major sporting events are supported by alcohol companies. And people who watch television or watch these events and go to these events tend to be younger people. So they're teenagers who are watching these events. And that's where the concept is introduced that drinking is cool. So I think worldwide there should be a ban on alcohol companies supporting sports events. And I'm happy to know that in India, alcohol companies cannot support sports events, cannot show advertisements at sport events.
Yeah. The only other thing before we move on to non-alcoholic fatty liver disease and viral hepatitis is most of the people who drink alcohol would also may be smoking. So you think that also adds on to a bit to liver disease, or it's okay?
Yeah, so that's important too, because we know patients who consume alcohol, we should very clearly tell them to stop smoking, because in patients who smoke, the risk of cancer is increased.
Right.
So not only liver cancer, but for instance, esophageal cancer is also increased. Additionally, we know that those who smoke and drink And smoking is sort of more difficult nowadays because the places where you can smoke becomes difficult. So if you see a patient who's smoking and drinking, it's going to be more difficult for you to try and get them off alcohol, because it suggests to them that the addiction is more of a problem. So the person who drinks without smoking is easier to treat than the person who drinks and smokes.
I think the other disease which you mentioned as maybe the second commonest cause of cirrhosis in US, and also it's increasing elsewhere, and the NAFLD is kind of a leading cause for liver transplant in US now, and may soon become maybe number one. So we know this is all related to the metabolic risk factors and related to metabolic syndrome. So it's a lifestyle disease again, as alcohol is also, I would say it is a lifestyle disease, and so fatty liver disease, non-alcoholic, is also a lifestyle disease. So what preventive aspects you think, other than say obviously the lifestyle changes, which obviously would be required to control these metabolic risk factors, or anything else which can be done to prevent this epidemic of say obesity or fatty liver disease?
I think worldwide this is a huge problem, because if you look at recent statistics about the prevalence of non-alcoholic fatty liver disease worldwide, it's about 25%. There is a fair correlation between amount of calories taken and prevalence, but not very clear. For instance, the United States as compared to South America, United States calories are higher than South America, but prevalence of fatty liver disease in South America is higher than in the United States. So we know there are genetic predispositions. I think it's a particular problem in Asia and India, because you can get insulin resistance at lower BMIs. So that weight reduction is clearly important. And I always look at NAFLD not so much as a liver disease alone. NAFLD is a pointer of risk for cardiovascular disease, because the number one cause of death is cardiovascular disease, and second is malignancy. For instance, if we look at cardiovascular disease, we have a recent publication which shows that if we take obesity and risk of cardiovascular disease, and we look at male and female, so we know for the same cholesterol, same BMI, females have a lower cardiovascular risk than men. We know that for sure. Right. But the moment you have NAFLD, whether in a woman or a male, right, the risk of cardiovascular disease increases independent of obesity, independent of diabetes and hypertension. So NAFLD is adding on something to that. Right. So for instance, a woman without NAFLD will get, her risk of cardiovascular disease increases after the age of 68. Mm-hmm. Whereas if she has fatty liver disease, it increases at the age of 50. So 18 years difference. Mm-hmm. And we know cardiovascular disease kills patients with NAFLD about 50 times more than liver disease. So cardiovascular increases. Second, one of my colleagues, Alina Allen, has demonstrated the increased risk of cancers in NAFLD, again independent of obesity and diabetes.
And when you talk about cancers, it's not only the liver cancer, they are the extrahepatic cancers as well.
Correct. Right. And it seems to be uterine cancer, right, gastroesophageal junction cancers, and pancreatic cancers increase. So the question is, if we know NAFLD is related to, abdominal obesity and probably mesenteric fat, whether the local factor of mesenteric fat increases your risk of local abdominal malignancies. We also know there's an increased risk of breast cancer in these patients. So not only are they dying of cardiovascular disease, they're dying of malignancy.
Fatty liver disease, the only peculiar thing which I would again like to ask you is, we talk about cirrhosis, we did talk about HCC as one of the complications and also becoming one of the killers for in liver disease, but then In fatty liver, the data which is now coming up that the patients can develop liver cancer or HCC even without going into cirrhosis. Let's not get into the pathophysiology. The question to you is, we did talk about the screening and the surveillance in cirrhotics for HCC. So where do you think that this kind of screening surveillance can be applied to patients with pure fatty liver disease but not amounting to cirrhosis as a prevention to HCC?
Ajay, I think you raised an important question here. So if we look at hepatocellular carcinoma with other etiologies, about 90 to 95% have advanced hepatic fibrosis, whereas in non-alcoholic fatty liver disease, it's about 80%. Problem here is who to screen, and do we have enough facilities to screen? Is it cost effective? How many additional tests are we going to do in these patients? And this is still a question which requires further investigation. So currently, we do not recommend surveillance for hepatocellular carcinoma with fatty liver disease.
Sure. The other thing again you raised earlier, and that we see very often in our part of the country, is the combination of alcoholic liver disease and metabolic syndrome. People are obese, hypertensive, dyslipidemic, and also taking a large amount of alcohol. So you think that this, and a terminology something like BASH, which you once suggested, could really be important, and both these risk factors could be synergistic in making your liver disease more advanced?
Yeah, for sure we know there is synergism. So if we say alcohol damages the liver, and let's say we give that a score of 1,
right,
and obesity damages the liver with a score of 1,
right,
the combination is 3.89, we know. So there is that synergistic effect in there for sure.
Right.
Differentiating the two is sometimes difficult because the amount of alcohol use required to cause damage is less if you're obese as opposed to if you're not obese. There are ways to differentiate. My colleague Vijay Shah, we've come up with an index which is available online.
Right.
You can get an idea about whether alcohol or non-alcoholic fatty liver disease is the dominant problem. But in general, I think the practical issue is if you have a patient who's obese and drinking, they have to lose weight and they have to cut back on alcohol. I think that is really the most important message from today's discussion.
Absolutely. And the last thing which you said, viral hepatitis, probably less common in US, especially Hep B. Hep C has been your major issue, but then it looks like it is all conquered. But what is your message to the Asia Pacific, other than the vaccination for hepatitis B, which has started happening in most of the countries at birth? Other than the vaccination, anything else you can suggest for prevention of viral hepatitis-related cirrhosis?
So there's hepatitis B and there's hepatitis C. So hepatitis C, we don't have an immunization. So then it's the question of effective treatment and decreasing the pool of patients infected so that it is spread. Hepatitis B, in addition to, so the younger people we are immunizing. The older ones, it's a question of testing for hepatitis B. So that I think it's good as part of a general examination if you're getting a blood test to do a test for hepatitis B.
And maybe screening for some more high-risk groups, or maybe pre-operative screening, pregnancy screening, dialysis screening. That can help us, in detecting more and more people and then maybe targeting them. Yeah.
Absolutely right. You mentioned the right groups.
Right.
And I think an additional group we should be concerned about is those on chemotherapy, because we can get hepatitis B flaring there.
All right. Okay. I think thank you very much, and we have had a good chat and discussion. I know the time was very less, and we really couldn't elaborate the way we could have done, and because of the time issue. But then thank you so much, and it was lovely chatting with you.
Thank you, Ajay.
Thank you very much.